we are moving into a relatively tough topic, that is on ILD, interstitial lung diseases. ILD is considered as a tough topic, and yes, it is a tough topic. But if you break down into small chunks and if you read and if you know how you approach it in a very organized, and if you know the pattern approach to ILD, it becomes much simpler. ILD is one of my basic areas of active interest. So I'll try to make it as simple as possible and as easy as possible. Let us go and discuss ILD along with me, and let us see how easy it is. Okay. First, you have to know the other name for ILDs, that is also referred to as certain books and many radiology guidelines tell this ILDs as DPLDs, called as diffuse parenchymal lung diseases. But anyways, we don't want to go into all those things. We'll stick on to the term called ILDs as of now. So as far as ILDs are concerned, the most important part is the initial classification. You have to be very strong in the classification part initially. You have to be extremely strong in the classification. So classification wise, I can split into three. ILDs, those have known causes. And second one, ILDs, those don't have any known cause. That is idiopathic completely. And third one, these are ILDs which have well-defined features and are rare, but they defy any particular classification, which means you cannot classify them under any particular class. So that's why these are called as rare ILDs with well-defined features. Well-defined features. So you can basically classify into these three segments. So now let us see what are the ILDs that have known causes. Number one, we have the topmost on the list, drug-induced interstitial lung disease. Whenever they say about this drug-induced ILD, I often tell the classic drugs that you have to remember that causes pulmonary fibrosis. You all know amiodarone, nitrofurantoin, methotrexate, bleomycin, busulfan. Classic. These are things you have to tell first. So let us tell that first. One is amiodarone. Second is nitrofurantoin. Third one is methotrexate. Fourth one is chemotherapeutic agents like bleomycin and busulfan. Remember, you can get with other drugs like cyclophosphamide also have been proven, but generally with cyclophosphamide it's quite rare. And there is another drug which doesn't cause pulmonary fibrosis, but it produces a non-cardiogenic pulmonary edema and ARDS-like picture. If they ask you what is the drug, cytarabine. Why I told you here? Because to remember along with these drugs. These are the drugs that are going to cause typically lung defects and lung problems. So very important drug, cytarabine, which is going to cause something called a non-cardiogenic pulmonary edema, like ARDS-like picture, not ILD. So just I told you just to understand the extra 1 point, that's all. So these are the classic drugs that you have to remember, and these are the drugs that are going to cause pulmonary fibrosis, and which means they are the ones that are going to cause ILD, extra cyclophosphamide, you can remember those also. Now, second, you have certain ILDs that are smoking related. You have some smoking related ILDs. Typically, you have three hallmark smoking related ILDs. One is called respiratory bronchiolitis ILD, respiratory bronchiolitis interstitial lung disease. Then you have DIP or DSIP, called as desquamative interstitial pneumonia. Desquamative interstitial pneumonia. Then you have pulmonary Langerhans histiocytosis. Previously, it was called as eosinophilic granuloma. We discussed about this in the hematology section itself under histiocytic disorders. Clear? Then number three, ILDs that happen due to connective tissue disorders. That's called CTD related ILDs. ILDs that happen due to connective tissue disorders. In that, very commonly you will get rheumatoid arthritis on the picture. You might get systemic sclerosis, that is scleroderma. You can get with MCTD, and you can get with polymyositis or dermatomyositis, especially those that are associated with your classic synthetase syndrome, anti-synthetase antibodies. That is the one that's going to result in ILD with a very high precision when they are associated with anti-synthetase antibodies. Especially anti-synthetase antibodies will be associated with polymyositis more than dermatomyositis. All these things we'll see in the rheumatology section. Then you can get with SLE also. But SLE induced ILD per se is very rare. Even though on paper it can produce, but we generally don't see SLE related ILDs that commonly. SLE means nephritis, CNS involvement, or probably hematological involvement, skin involvement. This is what we talk about SLE mostly. Rheumatoid arthritis, mostly with the joints, lungs. Lungs are very common sites for rheumatoid arthritis. As far as this mixed condition is concerned, yes, systemic sclerosis, one particular type of scleroderma you have to know, that is a diffuse type of scleroderma. More than limited type will cause pulmonary hypertension. Diffuse type is going to cause this ILD type of picture. Clear? So these are the things that you have to know. And very importantly, we are going to discuss n number of times in the rheumatology section again, but you have to know almost every CTDs typically causes NSIP pattern in histology. That is called non-specific interstitial pneumonia. But the exception is rheumatoid arthritis, which is going to produce UIP pattern. That is called usual interstitial pneumonia. Very, very important point. In rheumatoid arthritis, if they ask you the most common ILD pattern, the most common histological pattern, you have to answer it's a usual interstitial pneumonia. Whereas the most common pattern in all the other conditional disorders, when you take a biopsy in a patient suffering from CTD and they have ILD, you take a biopsy and so you're going to see NSAP pattern most often in all the other CTDs except for rheumatoid arthritis, where you will see UIP pattern. Very important point. Clear? Then, number 4, you can get with radiation related damage to the lungs, may result in fibrosis and ILD like picture. Then you can get with occupational disorders. There are a lot of occupation related ILDs. Again, these are known causes. What are the occupation related ILDs? If they are getting exposed to organic dust or if they are getting exposed to inorganic dust. If they are exposed to organic dust, that disorder will be called as hypersensitivity pneumonitis, where you will be exposed to cotton, bacterial products. If you are exposed to organic materials, this is what we call hypersensitivity pneumonitis. If you are exposed to inorganic compounds like silica, asbestos, beryllium, that will be called as pneumoconiosis. Clear? So these are occupation related ILDs. Number 6, you also have certain ILDs that is due to chronic aspiration, which means I can tell these are ILDs that are chronic aspiration related ILDs. So these are the ILDs that are due to known causes, which means you do have a lot of known causes for interstitial lung disease, which means when you are diagnosing an ILD, you should not straight away jump to the conclusion it's an idiopathic cause. You have to try to find out what is the underlying cause. That's the first basic thing I want to tell you. Then what are the ILDs due to unknown cause? Whenever ILDs are happening due to unknown causes, you can split into granulomatous ILDs and you can split into the second group called non-granulomatous ILDs. Only one granulomatous ILD I want to tell, that is sarcoidosis. Very, very important. This is the most important granulomatous ILD, sarcoidosis. Non-granulomatous, this group of ILDs which have unknown causes but they are non-granulomatous, they are called as IAPs. That's called idiopathic interstitial pneumonias. Idiopathic interstitial pneumonia. That's called IAPs. These IAPs are very characteristic in their pattern. Remember, only if they are not having any primary cause, they will be called as idiopathic. But if they have some underlying cause, you should not call them as IAP. IAP will be called only if they don't have any underlying cause. Let us see how will you classify, then I will tell you why this understanding is important. So idiopathic interstitial pneumonias, how will you classify them? First, you can classify them into IAPs that are associated with smoking. Even though this is an old classification, I am telling you, smoking. We know already 2 ILDs that are associated with smoking. One is called RBILD and second one is DIP. These are the 2 things that come under IAP previously. Now, a lot of books have displaced them from the IAP section to the known causes section. But anyways, this is the old one. Let us stick on to that. Smoking related IAP is only 2, RBILD and discombinant interstitial pneumonia. But pulmonary Langerhans histiocytosis is smoking related only, but that will come under Langerhans disorder. That's not something related to this idiopathic interstitial pneumonias. Then second group of IAPs you can tell, those which have chronic pathophysiology or they will have a chronic course. What are the chronic IAPs? One is called a UIP, that's called a usual interstitial pneumonia. Second one is called a NSIP, that's called a non-specific interstitial pneumonia. This UIP, if it happens idiopathically, we are also going to refer to as IPF, idiopathic pulmonary fibrosis. But remember, the same UIP and NSIP can happen in secondary causes also. So that is why I told you only if it's idiopathic, you have to classify them under IAP. If it's not idiopathic, then you should not put under IAPs. You have to tell under some CTD or some other reason that is causing them. They are secondary ILDs only. They are not idiopathic and primary IPs. Please do understand. Clear? Suppose if rheumatoid arthritis is producing UIP, pattern histology, you should not call them as IPF, idiopathic pulmonary fibrosis. But if you don't have any underlying cause, if you have ruled out all the underlying cause, especially rheumatoid arthritis, patient is presenting with a UIP picture, then you can call the disorder as idiopathic pulmonary fibrosis. Otherwise, you should not call. Simple. Then those IAPs, idiopathic interstitial pneumonias, that have acute or subacute presentation. Acute or subacute presentation. There are two IAPs that are going to have acute and subacute presentation. Number one, you have acute interstitial pneumonia. This is often related to, like ARDS, because they are going to present like ARDS only, their course will be like ARDS only, but they don't have any secondary cause. This I have told you in the ARDS video itself. But anyway, it's not good to call it as an idiopathic ARDS. It's very bad. So just call as AAP. It has a name, acute interstitial pneumonia. That's all, which will be acute in presentation. There is a second one which is subacute in presentation. That's called a cryptogenic organizing pneumonia, which was previously called as BOOP, bronchiolitis obliterans organizing pneumonia. Otherwise called as cryptogenic organizing pneumonia, which is typically going to have a subacute presentation. Okay. Then finally, you have very rare group of ILDs or very rare group of idiopathic interstitial pneumonias which don't even have a proper incidence. Number one, we call it as lymphoid interstitial pneumonia. Even though ILIP is said to be a subtype of NSIP, I don't believe it's a separate type. Lymphoid interstitial pneumonia, if you study histology properly. Lymphoid interstitial pneumonia. Second, you have another type of IAP called pleuroparenchymal fibroelastosis, of which we are not going to discuss right now. So these are the things that will come under the idiopathic interstitial pneumonias, that is non-granulomatous typically. Granulomatous ILD, unknown cause, means only one thing, that is sarcoidosis, which is typically going to produce non-casseting granulomas, which you're going to see in detail in the subsequent videos. What are the rare ILDs that are going to have well-defined features, but they defy any particular classification? First one, we have something called a LAM. That's called a lymphangioliomyomatosis. Lymphangio, I'll write it down. Lymphangio-leiomyomatosis. Typically, what are the features? I'll discuss in detail in the subsequent videos, but still let us see the well-defined features of this particular ILD. What they will ask you in exam. Number one, you are going to get typically in females, and most often it is due to mutation in the tubercular sclerosis gene that will be affected. Even in congenital cases, or even patient tuberous sclerosis, or even in sporadic cases, this TSC gene involvement is very important. Tuberous sclerosis in lymphangioleiomyomatosis. Usually, the presentation will be in the mid-30s. How they will present is going to be in the recurrent pneumothorax and chylous pleural effusion, or you can tell chylothorax. Recurrent pneumothorax and chylothorax, chylous effusions. This is how they are going to present. Clear? And in CT, characteristically, will result in Swiss cheese appearance. There will be a lot of cysts with ground glassing in between. That's what we call Swiss cheese appearance. What is ground glassing? We will see in some time in the same video. Number two, you have another disease called chronic eosinophilic pneumonia. Chronic eosinophilic pneumonia. In this patient, the patient will have eosinophilic infiltrates in the pneumonia, but idiopathic, unknown cause. If you have a known cause for this eosinophilic infiltrates in the pneumonia, like parasite infection or something else, you cannot call this as a chronic eosinophilic pneumonia. You cannot call it as a eosinophilic pneumonia or acute or chronic, whatever. You should not have any cause. You have ruled out all the causes. Still, lung is showing some infiltrates which is filled with eosinophils. That is what we call the chronic eosinophilic pneumonia. Clear? So what is the typical feature that you want to look out for in a chronic eosinophilic pneumonia? Very simple. In chest X-ray, one classic finding has been described, that is what your exam question will be, that is called a photographic negative of a pulmonary edema. We have subsequent discussion, don't worry, in videos I'll show the images also. Photographic negative of a pulmonary edema. So what do you mean by photographic negative of a pulmonary edema? You have lungs like this. Typically, you know one important thing, that in pulmonary edema, your infiltrates will be predominantly concentrated in the hilar region, and that is also the reason why you get this bat wing appearances and all. But in case of eosinophilic pneumonia, chronic eosinophilic pneumonia, the infiltrates will be predominantly in the periphery. All the changes you will be seeing in the periphery. Since it's exactly opposite to what you see in the pulmonary edema, that's what we call it as photographic negative of a pulmonary edema. It's not hilar, it's peripheral, and it's one disease that typically involves the upper lobe more than any other lobes. And if you take a bronchoalveolar lavage in any eosinophilic pneumonia, acute or chronic, you are going to see very, very high levels of eosinophilia, eosinophilic bulk. All these are very typical features of chronic eosinophilic pneumonia, but you should not have any other secondary cause for this. You have to rule out all the secondary causes, then only you can diagnose this disorder. Third one, you have a special disorder called PAP. That's called a pulmonary alveolar proteinosis. Like there are a lot of types of PAP. You have primary PAP and secondary PAP. Secondary PAP will have some causes, like for example, even HIV can cause PAP, silicosis can cause PAP. Like this, lot of conditions can produce PAP, pulmonary alveolar proteinosis. The primary PAP, who will get? Typically, these patients will be males and smokers. A smoking male is very characteristic, usually in the 40s. And when you take bronchoalveolar lavage from these patients, they will be showing something called a milky ball. That's called as milky bronchoalveolar lavage fluid. They'll be very turbid and milky. That is because these patients produce pulmonary alveolar proteinosis, means they'll be producing some proteinaceous material, which is nothing but a surfactant, either in excess or poor clearance. Something will happen because of that. The excess surfactant is what is secreted as this proteinaceous material, and that's what you will see in the sputum of these patients, and also that's what you will be seeing in the ball lavage washing also. And CT is typically going to show something called a crazy pavement appearance. All these things we'll be discussing in this particular video. Crazy pavement appearance. Even though this crazy pavement appearance is not specific for pulmonary alveolar proteinosis, it was first actually described for this PAP only. That is why it becomes so famous for pulmonary alveolar proteinosis. Clear? In protein energy malnutrition, you see crazy pavement dermatosis. That's in pediatrics. I'm not talking about that here. It's an X-ray CT appearance where you see crazy pavement appearance. So this is how you classify the ILDs in the first place. You have to be very, very, very clear in how to classify the ILDs in the first place. Now you have classified the ILDs and how these ILDs behave overall. Let us see some gold standard points in ILDs. Some of the facts that you should know in ILD. Number one, what will be the most common clinical feature in ILD? The most common clinical feature is they present in a chronic fashion. Number one. Even though a lot of subacute diseases are there, usually they tend to present in a chronic fashion. Second, they tend to produce dry cough and shortness of breath. This will be there in almost every single ILD. Almost most of the ILDs is going to present like this only. But a lot of exceptions are there. Obviously, there is no rule in medicine. You might have a lot of exceptions, right? So what are the exceptions you might have? For example, some exceptions you can see where typically I told acute interstitial pneumonia is going to present acutely. And cryptogenic organizing pneumonia, that is BOOP, is going to present in a subacute fashion, not a chronic fashion. Probably other disorders like hypersensitivity pneumonitis do have acute presentations and subacute presentations also. A lot of occupational disorders like silicosis, other occupational disorders like silicosis also has acute presentation, and etc. So many exceptions you can tell, but these are the important exceptions that you have to know, which have no chronic presentation. Instead, they're going to have a subacute or acute presentation. Then you have this dry cough and shortness of breath, but they do have some exceptions. Best important exception is going to be the PAP, pulmonary alveolar proteinosis. They will be having a lot of productive cough in PAP. That is because the surfactant is not cleared or secreted in excess. Because of that, they will be expectorating this surfactant. I told you already. That's the reason for the milky ball. So productive cough, PAP. Many other conditions also may produce, but very commonly, this is how they produce. Subacute chronic presentation. Typically, they come with a dyspnea with a dry cough. This is the presentation of an ILD. Fine. But with some exceptions, all right. And examination wise, they will ask you an important finding in ILD, any ILD, that is your end inspiratory fine crackles. When you examine this patient, you are going to classically find this dry end inspiratory crackles. And this dry type of crackles in ILD is also typically defined as something called Velcro type of crackles. You would have all seen the Velcro. It's going to look like that. These are called as dry crackles. For example, in bronchiectasis and all, you will see a very coarse, wet crackles. And if you start in hearing all these things, you will definitely know how these things will look like. But here you're going to see a dry, Velcro kind of crackles. End inspiratory. Very, very classic. So this is for ILD. But remember, this presence of Velcro crackles has a very poor sensitivity, which means this is a late sign. And it's a sign of fibrosis. Late sign, and it's going to be a sign of fibrosis, which means in many early ILDs, you won't get this sign. You won't get this Velcro crackles. At the same time, if this sign is present, it itself is a very ominous sign. Why? Because it indicates fibrosis and irreversibility, and you cannot give any treatment. So presence is very rare, poor sensitivity. If this thing is absent, it doesn't mean that you don't have an ILD. But if this thing is present, likely to be an ILD, but with a fibrosis and a poor prognosis, which means it's not going to respond to treatment because it's fibrosed. That's what you have to think about this particular sign. Clear? Then, what are the other things that you can look for? Other things, then you can do a pulmonary function test. Typically, most common pattern that you will expect in a pulmonary function test is a restrictive pattern. Restrictive lung disease pattern that you're going to see, where you will have a low FVC, which will be dramatically decreased, and you might be seeing a reduced residual volume, a reduced total lung capacity. At the same time, you might be having normal FEV1 by FVC ratio. Clear? Typically more than 0.7. In fact, this will be more than 100% in many cases. Typically, the flow volume loop that you're going to get in these patients, suppose if you take, this is the normal flow volume loop. There are two types of flow volume loop you can get in ILD patients. One is something like this, where the shape might be completely normal, where your FVC will be seriously declined, and it looks like entire lung itself has become smaller in size. This is the common pattern that you get. But in patients who are having ILDs with severe reduction in the compliance, you can also see a flow volume loop, something like this. This is called hamburger shape, where you might see an extremely low FVC. FVC may be seriously impaired because of the curve looks flattened on the top, which means your PFR may appear falsely elevated. So this is what we call hamburger shape. Anyway, so these are the two flow volume loops that you're going to get in ILDs. But if they ask you the earliest change in ILDs, that is reduced DLCO. In very early ILDs, you will be having entirely normal spirometry sometimes, but you will have a reduced DLCO, because ILD is a characteristic example of a diffusion limitation. How many times we have discussed? ILD and emphysema are two characteristic disorders that cause diffusion limitation. That's why this reduced DLCO is characteristic of them. RLD with reduced DLCO means you have to immediately tell ILD. OLD, obstructive lung disease with reduced diffusion, means immediately you have to tell emphysema. It should be told in the sleep itself. Very, very important, both these disorders. At the same time, your saturation, SpO2, typically tends to be normal at rest, at least in early stages, whereas they are going to desaturate on exercise. Desaturate with exercise. Why they desaturate with exercise? Simple reason, because ILD is a diffusion limitation. The characteristic feature of a diffusion limitation, again we have seen multiple times, is desaturation with exercise or dyspnea on exertion. Very, very important point. Clear? Now we are moving on to the other things. So what are the things that ILDs you don't get very rarely? Rare features of ILD include, number one, your pleural effusion, and second one is pneumothorax. These two things are extremely rare in ILDs. You don't get, very, very, very rare. But again, there are some exceptions where this pleural effusion and pneumothorax both can be seen in your lymphangioliomyomatosis and another disease called pulmonary Langerhans histiocytosis, where your pneumothorax is very, very common. Pulmonary Langerhans histiocytosis. Clear? Where pneumothorax is very common. in LAM, in lymphangioliomyomatosis, I told you the presentation itself. I told you it's a well-defined feature, no? Here you can see the presentation itself is recurrent pneumothorax and chylothorax. That is chylous effusion. That's why I told you this is a very important exception in ILDs where recurrent pleural effusion pneumothorax means it's LAM, and pulmonary Langerhans histiocytosis will present with recurrent pneumothorax also. But apart from that, there are some rare cases of sarcoidosis also who's coming with pleural effusion, even though you tell the classic no's in sarcoidosis. What are the no's in sarcoidosis? No pleural effusion, no pneumothorax, no adrenal involvement, and no cacheating granuloma. So which means no caseation, no cavitation, no pneumothorax, no pleural effusion, no adrenal involvement. These are the classic no's in a sarcoidosis, which we'll discuss. But this is not the rule, 100% rule. I told already, never say ever in medicine and never say never in medicine. So this is a rule. So sarcoidosis also, we have seen certain cases which do come with a small effusion, and sometimes even they have come with the pneumothorax. So don't worry about that. Even PCP pneumonia is a type of interstitial lung disease only, but they do produce a lot of pneumothorax. So pneumocystis carry pneumonia and HIV. So please, like a lot of exceptions are there, but in general, ILDs do not produce your pneumothorax and pleural effusion that often. So this is a very important point again to note. And number 5, HRCT. This is overhyped in many places, and yes, it lives up to the hype because CT is what is going to be the most important for diagnosis of ILD, high resolution CT, and this is the gold standard for pattern analysis of ILD, and this is the gold standard for any, if they ask you imaging modally, that's the gold standard, definitely it's going to be HRCT only. No ILDs can be diagnosed without HRCT. Say chest X-ray just bows down and it just falls on the floor. It's definitely inferior. You cannot diagnose anything through chest X-ray. You can find out some problem may be there in chest X-ray, that too in medial to advanced disease you might find out, but very, very difficult to find out early disease in chest X-ray, where the chest X-ray may be completely normal, or even late disease. You can find out there is some issue might be going on, but you cannot tell exactly what is going on. The CT is the one that's going to clearly kill you the diagnosis most of the time. It brings your diagnosis on plate. So that's why HRCT is going to be the gold standard imaging modality for ILD diagnosis. Fine. Let us see the pattern approach. So in the pattern approach, I'm going to show a lot of, first see the lobar predominance, then we'll go what type of pattern you see in the HRCT. But still, stay with me. First, let us go for the lobar approach. So what are the ILDs that have upper lobe predominance, and what are the ILDs that have lower lobe predominance, and what are the ILDs that prominently present with lymphadenopathy, and what are the ILDs that tend to have pleural disease that is associated pleural disease. Clear? Like pleural thickening, pleural fibrosis and all. That's what I'm talking about. So ILDs with upper lobe predominance. You have to tell almost every single your occupation related pneumoconiosis is going to have upper lobe predominance only, except one pneumoconiosis, that is asbestosis. You have to be very clear. So your coal workers pneumoconiosis, definitely upper lobe predominance. Then you have silicosis, definitely upper lobe predominance. Then you have berylliosis, again definitely upper lobe predominance. But one pneumoconiosis that is going to have lower lobe predominance is asbestosis. This is a multiple times asked question. Clear? Then you're also going to get upper lobe predominance with sarcoidosis, even though sarcoid in ILD we call it as a great chameleon. It can present like anything. Whatever patterns I'm going to tell later on, I'm going to discuss, sarcoid can present in every single way, every single possibility sarcoid has. So don't think sarcoid is going to be like that only. It can be anything and everything. So sarcoidosis is typically upper lobe, but let us keep it subtle. Then ankylosing spondylitis, upper lobe fibrosis, rheumatology section. I will definitely explain that. Ankylosing spondylitis is one of the important extra-articular manifestation is upper lobe fibrosis, along with your aortic regurgitation and mitral valve prolapse. Clear? Very important, multiple times asked question. Then you might get with pulmonary Langerhans histiocytosis, then chronic hypersensitivity pneumonitis. Chronic hypersensitivity pneumonitis. All these things will have upper lobe prominence only. Remember, rheumatoid nodules are common in upper lobe. Rheumatoid nodules, that is Kaplan syndrome. Rheumatoid nodules are common in rheumatoid arthritis, common in upper lobe. But ILD in rheumatoid arthritis is common in the lower lobe only. All CTD related ILDs happen in the lower lobe because they are either NSIP or UIP, which typically tends to have lower lobe predominance. Be very, very clear about that. Rheumatoid arthritis, nodules of rheumatoid arthritis, lung nodules of rheumatoid arthritis tend to happen in the upper lobe. Kaplan syndrome, which is associated with these rheumatoid nodules, tend to happen in the upper lobe. But please be very sure, the ILD, that is your rheumatoid connective tissue disorder related ILD, will always be in the lower lobe only, predominance. So these are the important things. In this, the most important will be the all pneumoconiosis except asbestosis. Definitely your sarcoidosis is not that important here. Your pulmonary Langerhans histiocytosis is definitely important. What are the other diseases? I'm not talking about ILDs, but other disorders that can cause upper lobe predominance. Just for trivia, I'm asking. So if somebody asks you other disorders that have upper lobe predominance, you can easily tell ABPA, allergic bronchopulmonary aspergillosis, histoplasmosis. It's a TB of the Western world, histoplasmosis. Then tuberculosis. So all these things also will have upper lobe predominance, but these are the classic diseases that you have to remember for exam. What are the ILDs with lower lobe predominant? First is asbestos, we discussed already. Then IPF, typically idiopathic pulmonary fibrosis. CTD related ILDs. I told you already. Any conditions of ILD will be predominant in the lower lobe only. Then finally you have drug-induced ILDs. Drug-induced ILDs. All these things will have typically lower lobe predominance. As simple as that. What are the ILDs that present with adenopathy? If they ask you lymphadenopathy and ILD, first thing you have to discuss is sarcoidosis. That's all. This will be the first possibility all the time. Common things are common always. First is sarcoidosis. Second, you can think about berylliosis. It is a cousin brother of sarcoidosis, which means many times this berylliosis and sarcoidosis, I cannot even actually differentiate. You need a lot of other tests called BLIPT, beryllium lymphocyte proliferation test. All you need. It is that difficult to differentiate from a sarcoidosis. They present and mimic exactly how sarcoidosis comes. Berylliosis. It's an occupational disease only. It's a pneumoconiosis due to beryllium exposure. Then you can get with silicosis. Silicosis also produces adenopathy, but not that commonly. And other causes, if they ask you, that can present like ILD, but not related to ILD, but still can present adenopathy, is definitely TB, malignancy, and whole lot of fungal infections, including histoplasmosis. All these things you have to remember. Whenever you think about a adenopathy, other things also you have to remember. Even though these other things I'm telling just for extra, it's very important. They are not related to ILDs anyway. What are the ILDs that are pleural disease? Number one is almost very important, that is asbestosis. Once again, you will have benign pleural plaques, very, very important, that restrict the lung many times. You can produce a restricted lung disease with just a pleural plaques, which prevent the expansion. Simple. Then you can get with radiation. Radiation-induced ILDs very commonly have pleural thickening and pleural fibrose also. Then you might get with some connective tissue disorders. Certain CTDs also produce pleural involvement, like rheumatoid arthritis can produce pleural effusions. We have seen already, SLE can produce pleural effusions. Some CTDs also can produce pleural involvement. And lymphangioliomyomatosis, they do have a little bit of pleural involvement, like chylous effusions and pneumothorax and all. So these are some of the ILDs that you can expect in relation with the pleura. So this is a very important first pattern approach, which lobe and which area they are predominant. Then we can go to the pattern approach per se. Pattern approach per se. This pattern approach per se is very important, and we are going to see through our HRCT basic interpretation. This is how we are going to see. So what you are going to see in HRCT as a pattern approach. The first pattern we are going to call as reticular pattern. Remember, which means I am telling predominantly only. There could be, if I tell you nodular pattern here, for example, next I will be telling nodular pattern. Then I will be talking about consolidation pattern. Then I will be talking about ground glass pattern. Then I am going to finally tell about cystic pattern. If I tell you 5 different patterns, the most important thing here to understand is the fact that these 5 different patterns is not like the ILD will come only under that particular pattern. First of all, you have to understand ILDs can overlap between different patterns. For example, you can see ground glassing in a patient who is having sarcoidosis, and you can see a nodular appearance in a patient who is having sarcoidosis, or you can see a reticular pattern also in a patient who is having sarcoidosis. That's why I told you sarcoidosis is a great chameleon. So same ILD, same disease can produce different patterns in the lung. Point number 1. But we are going to discuss the most common patterns, what they are going to produce. Most often what they will produce. Okay. Similarly, it's not like reticular means the patient will have only reticular. It's not like nodular means patient will have only nodular. They can have a reticulonodular pattern, or they can have a cystic appearance with ground glassing. So it's not like they will have only one particular type of pattern in the lung. They're going to have a lot of overlaps. That's what makes ILD interesting as well as difficult. Clear? So predominantly, whenever you think about reticular pattern, it's about the interlobular septa. That's what we're talking about, and we have discussed that in the first chapter itself. What is about secondary pulmonary lobule? What is the interlobular septa? And if you don't know now, please go back and visit that again, because that's going to be very, very important, crucial in understanding. Then nodular appearance. Whenever you have a nodular appearance, you have to again see another pattern, whether these nodules are distributed in what manner, whether they are centrilobular nodules or they are perilymphatic nodules, or third thing, random nodules. They don't follow any distribution. So this is very important for nodular pattern. And typically this consolidation and ground glassing is called high attenuation pattern, which means they look bright. And typically this cystic pattern is called as low attenuation pattern. Cystic means it's a low attenuation pattern. Emphysema is also low attenuation pattern only, where it will be more air than required. Cystic is a low attenuation pattern. These are completely different. Nodular is completely different. Reticular is completely different. Reticular means it's typically going to affect the interstitium only. Clear? And this consolidation typically affects the airways. Consolidation typically is going to affect the airways. Definitely, whenever the moment you call consolidation, it's an airway disease, that's all. They're going to affect the airways. Ground glassing again is something overlapping. It can be seen in interstitial disease, it can be seen in airway disease, or it can be seen in a combined interstitial and airway disease. So ground glassing is something, a lot of overlap will be there. And typically cystic is something different, where you see a low attenuation. It's a cyst full of air pocket in the lung. That's cystic. So let us go and visit the secondary pulmonary lobule again in a very simple way. You know the secondary pulmonary lobule, you'll have a pleural space, you'll have a hexagonal or a little bit haphazard icosa polyhedral structure that is going to be the basic functional unit of the lung. So which I have drawn here is going to be the interlobular septa. Interlobular septa. This is going to be the pleura. Clear? That is the visceral pleura. And I told you already, this will be supplied by a lobular bronchiole. Some books will tell lobular bronchus. Let us stick on to the term lobular bronchiole. And this lobular bronchiole will be accompanied by the branch of the pulmonary artery, obviously. Branch of the pulmonary artery. And they divide into multiple terminal bronchioles, which further divide into multiple alveolar ducts and respiratory bronchiole. And they are going to form a lot of alveolar sacs and acinus. Then your pulmonary artery is going to give rise to capillaries, which will result in oxygenation of the blood in the alveoli, and from there they will join and they form the pulmonary veins. Not only the pulmonary veins, your lymphatics are also going to go along with the pulmonary veins, which means it's very clear the septum, if you see, zoom in and see the septum is not only contributed by your septum actually, which means the septum also has pulmonary veins in it. The septum also has lymphatic ducts with them. The septum also has connective tissue that is actually forming the septum. These are three things that form the septum. So important thing to understand is that problems with any of this, for example, in pulmonary venous congestion, or you have a problem in the lymphatic duct or lymph accumulation there, or if there is thickening of this connective tissue called interstitial thickening, in all these disorders, you might have problems with this septa, and which means the septum may appear thickened. That's the idea. So let us move on and see the basics of how you're going to get different patterns of ILD. So let us move on to this and let us see. So what I showed here is these are the airways and air spaces. That are containing air. And this is going to be the interstitium. Typically, if it's a secondary pulmonary lobule, you can understand this is the substance of the secondary pulmonary lobule and this is the interlobular septa. Let us assume like that. So what do you mean by a consolidation? So this particular areas which have not shaded at all, these areas I can call them as consolidation, because here the air from the airways is completely displaced. Air from the air spaces is completely displaced, and you are getting some other substance. Instead, alveoli is filled with something else. Alveoli is filled with something else. This is called alveolar filling process, and it can be with pus, it can be with water like pulmonary edema, it can be with blood in case of a pulmonary hemorrhage, anything. So this is what is going to happen. Or inflammatory infiltrate cells in case of bronchoalveolar carcinoma, it's only the cells that fill the alveoli and that looks like a consolidated area. Or it could be an inflammatory infiltrate. So anything that fills the alveoli and displaces the air out, that area will look white. That's called consolidation. That's why I told you, the moment you call consolidation, it's an air space disease. That's all. Alveolar problem. Simple. Then coming to what are the other possibilities. Suppose if you have high attenuation, for example, if you have so much of air, but typically you don't see that interstitium here, only air pocketed in a particular area, this is supposed to be cystic. Or in a defined manner, you can call it as emphysema also in certain areas. If you have a well-defined features that suggest you have emphysema, the pattern, you can call emphysema also, but in ILD terms, we call them as cystic. Why? Because completely black, more air than what you expect, which means no interstitium at all, nothing, it's only air. No blood vessels, nothing else. Bulla looks like this. Emphysema lungs, depending on the pattern, looks like this in certain areas. Cystic ILDs look like this, like lymphangioliomyomatosis, important cystic ILD. Langerhans cell histiocytosis, Makos cyst, looks like this. Clear? Then, there are certain areas, I told you, here the air spaces are completely devoid of air, which means complete displacement of air. That's your consolidation. But if there is a partial displacement of air, let us assume there is no complete displacement, but you are having only a partial displacement of air like this, which means there is some air which is still going on, but you have a partial displacement of air. Little air is left, little air is gone. What do you call it as? This is what we refer to as ground glassing. This is what we are going to call it as ground glass appearance. It's partial displacement of air. That's it. Suppose if you are going to get this reticular lines very prominently, this is what we refer to as a reticular pattern. And there are certain ILDs which show reticular pattern. And if you are going to get nodules, like for example, nodules, I told you it could be centrilobular, it could be your lymphatic distribution, that's called perilymphatic nodules, or it could be random nodules. What are they? Suppose if your nodules are located in this area, that is along the septum, that's lymphatic area. That's why it's called a perilymphatic nodules. Typical example, lymphangitis carcinomatosis. Many carcinomas can produce this. Second pattern you can get in the central area of the secondary pulmonary lobule. This is centrilobular distribution. Or you can get not in a very defined distribution. This is also referred to as random. So this is a random nodule, this is a centrilobular nodule, and this is going to be a perilymphatic distribution of the nodule. This is a perilymphatic nodular distribution. So you have seen so many patterns. Nodules we have seen what is ground glassing, we have seen what is consolidation, we have seen what is cystic. So a lot of things we have seen, and reticular pattern also we have seen. But I told you this ground glass may happen in airway disease, which means it can happen with airspace disease. This ground glassing can happen with interstitial disease. This ground glassing can happen even with combined airspace and interstitial disease. Combined airspace and interstitial disease. All these areas you can see ground glassing. How is it possible? In airways, let us assume there is some material that is partially filling the alveoli, not completely filling the alveoli, which means some amount of air will be displaced and some amount of air will still be there. That's going to give rise to a ground glass. Second, suppose if the interstitium is thickened so much, again this thickened interstitium will reduce the volume of the particular airspace, which will result in movement of some air out of the particular airspace. Only some air will be there, less air. That's what is going to produce a ground glass. Or it can be seen in a combined airspace and a interstitial disease. That's how you get ground glass. A lot of overlaps with ground glass is there. So let us see some of the causes of each and every particular type. First of all, what is ground glass? You don't have that pitch darkness like cystic. It won't be like a normal alveoli also. It will be just less. It won't be like a consolidation also fully wide. It will be between a consolidation and a normal airspace. It will be somewhere in between. Little less, but little bit high attenuating. So that's what we call ground glassing. Typical example of a ground glass. So let us see some of the images which are of very paramount importance after this understanding. So these images are something related to reticular pattern. Number one. What do you mean by reticular pattern? You can see here, this typically affects this interstitial spaces. You can see very clearly interstitial lines. This is very typical and classic example of a reticular pattern. This is a case of idiopathic pulmonary fibrosis. We'll discuss in later on in the subsequent videos. And you can see here also is a very, very early in idiopathic pulmonary fibrosis, where you can see this subpleural arrangement of this interstitial lines. These are typical example of interstitial lines, how this look like. You can see little bit your interstitial lines are more here. So these are reticular densities. Again, this is a characteristic example of a reticular density, where you can see these reticular lines are actually thickened here. Clear? These are the reticular lines that are thickened. So this is again a characteristic example of a reticular opacity. But what you are seeing here is, in this condition, you are seeing this reticular opacities bilaterally. These reticular markings that are increased here, it's bilateral. It's not unilateral. But in this example, it is unilateral. Such type of unilateral increase in reticular density is really, really important. According to me, it is the most important. Why? Because whenever you see unilateral increase, that too very focally, you are having this increase in the reticular densities. In the reticular areas, it is increased in density. Usually, it goes towards a diagnosis called lymphangitis carcinomatosis. Lymphangitis carcinomatosis. Very, very important. Usually, this lymphatic spread of the malignancy in the lungs can happen in many cancers like breast cancer, stomach cancer. Lot of solid organ cancers can produce this lymphangitis carcinomatosis. Very, very important point, especially with unilateral. In a focal area, this reticular densities are increased. Very typical diagnosis in exams. And second, bilateral, you not worry about lymphangitis carcinomatosis that much. It's a bilateral disease. It's a bilateral one. It's a hardcore IPF. It's very, very hardcore IPF. We'll discuss the features later on in subsequent videos. That is idiopathic pulmonary fibrosis. That's it. Hardcore IPF. Where bilateral, you are seeing reticular, and many times if the reticular densities become very coarse and very thick, here you can see here they are thin reticular densities. It's not that thick, but here you are seeing very, very thick reticular densities here, and sometimes they can form this air spaces which are trapped within this thickened reticular densities called as honeycombing. And honeycombing usually results from a coarse reticular feature. Whenever the reticulations become so thickened, the air spaces may get trapped within these reticulations. They will contain air, but surrounding full white colored lines that will go around and they form severe coarse reticulations. And that kind of air space is what we call as honeycombing appearance. Clear? So again, it is very common with reticular densities, especially in late stages when the fibrosis becomes obvious. So let us see some of the differential diagnosis. Now we have known what you mean by reticular density in real-time cities. So let us see some of the examples. Examples of what is going to produce reticular densities. Number one, you can get with IPF and many other ILDs, IAPs can produce reticular. But classic example that produce reticular densities is IPF, idiopathic pulmonary fibrosis. In exam, if you know at least this, it is more than enough. Then you can get with asbestosis. You can get with other pneumoconiosis. You can get with sarcoidosis. You can get with radiation pneumonitis. As I told you, there is one important differential diagnosis that is called lymphangitis carcinomatosis. Very, very important. Lymphangitis carcinomatosis. Then you can get with continuity disorder related ILDs, drug induced ILDs, berylliosis. I should have told there itself, pneumoconiosis. So, lot of conditions can produce this reticular pattern. But classically in exam, you have to remember this idiopathic pulmonary fibrosis. And second thing, I believe the most important will be the lymphangitis carcinomatosis. It's a very, very important thing, especially if it's unilateral history of breast cancer or stomach cancer or any other solid organ cancer is there. Straight away go unilateral reticular pattern focally, thickening, gone. It is a lymphangitis carcinomatosis, lymphatic spread of the malignancy. That's it. Clear? So these are the things that you have to look for. Next. So what is this? You're going to tell this. This on the board, you can clearly tell this is a consolidation. This is how it looks like, typical consolidation. Because you can see it's full of white structures here. There is nothing else. The entire airways in this area, air spaces in this area is completely filled with some material. So it's complete displacement of air. So there is no black at all. It's full white. Alveolar filling process. That is equal to consolidation. That's all. What is filling here? This is an example of a cryptogenic organizing pneumonia where plugs of granulation tissue will be filling the alveoli. So bronchioles and the alveoli. So this is called cryptogenic organizing pneumonia that's going to come with inflammatory infiltrate that will fill the alveoli. Is the example. This is a patient with a cough. And you can see this patient is also having this consolidation here. This is definite consolidation. There is no air you can see here. This is fully filled with some material. This is again another example of a cryptogenic organizing pneumonia. COP. Lot of examples of consolidation are there. For example, what are things that can produce consolidation? I told you pus can fill. When pus can fill? Whenever there is an infection, it can produce consolidation. For example, a bacterial pneumonia. This bacterial pneumonia is the classic example of a consolidation. Classic. That's why it's called a typical pneumonia. But remember, you might get with the eosinophilic pneumonia, other pneumonias also, like eosinophilic pneumonia. You can get with certain organizing pneumonias, I told you, like cryptogenic organizing pneumonia, which is otherwise previously called as BOOP, bronchiolitis obliterans organizing pneumonia. Or you can get with other infections like mycoplasma, PCP, virus. But in exam, at least a classical condition, you have to know about the bacterial pneumonia. Very, very trivial, naive and classic condition. You're going to get this bacterial pneumonia, typical lobar pneumonia, you get a consolidation. That's how consolidation started in the first place, in the old era. Now, you can fill that with water. Water can fill that space. Typically happens in ARDS and cardiogenic pulmonary edema, because ARDS is a non-cardiogenic pulmonary edema. Third, you can tell acute interstitial pneumonia. Simple. Acute interstitial pneumonia is like ARDS only. I told you already. Then a tumor can cause a consolidation. If they ask you a tumor causing consolidation, only one possibility you have to tell, that's a bronchoalveolar carcinoma. Bronchoalveolar carcinoma. I told you this point already in the previous slide. Bronchoalveolar carcinoma is a characteristic example of a tumor, a lung tumor producing a consolidation. They come with consolidation only, because this tumor cells will actually fill up the alveoli and they look like a consolidation only in CT or chest X-ray. It's a very important point. And lymphoma sometimes rarely can produce consolidation, but let us stick on to this term. This is the most important, bronchoalveolar carcinoma. Then you can get with fibrosis, a fibrotic material. In late stages of fibrosis, the fibrotic material itself can completely fill up the alveoli, producing consolidation-like appearance. It can happen with your idiopathic pulmonary fibrosis, that is UIP. You can happen with certain NSIP feature. You can happen with radiation-induced fibrosis, or you can even get with sarcoid patients or some other material. For example, a protein filling the alveoli. That happens in a PAP, pulmonary alveolar proteinosis, where the surfactant fills the alveoli because of poor clearance and increased production. So these are some of the important causes of consolidation if you want to know. So this is alveolar filling, that's it. Or even hemorrhage, we didn't talk about that. Even it could be blood in a patient who's having an alveolar hemorrhage called as diffuse alveolar hemorrhage, like Goodpasture syndrome, pulmonary hemorrhage. In these conditions also you might get consolidation. So these are the classic cause of consolidation. But I believe the most important for exam will be bacterial, of course, then this cryptogenic organism pneumonia, of course, and the third most important will be bronchoalveolar carcinoma, which is having a lot of clinical relevance. These three things, do not forget. So we have discussed enough on consolidation. Now, what are the other patterns that are important as well, like ground glassing, cystic, and all these things we're going to see after this. So this is what the characteristic ground glassing that we are talking about. So what does it mean? I told you it's due to partial displacement of the air, which means you can get the ground glass due to interstitial disease, or you can get the ground glass appearance in an airspace disease or alveolar disease. You can get in the combined interstitial as well as airspace disease. Let us see one example for each. Then I will tell you what are the examples of ground glassing. So this is a typical example of ground glassing where you can see this kind of densities over here. These are not so white like consolidation. These are not black like normal lung also. So this is a normal lung. This is a normal lung here. But these are all areas of ground glassing. That is, they are somewhere in between. They are not fully black like cystic. They are not fully white like consolidation. They are not like normal lung also. They are somewhere in between, like partial displacement of. They will contain some air, but it is partially displaced. Some air is left, some is not there. That's what we call a ground glass. So this is a typical example of a NSIP, non-specific interstitial pneumonia. So whenever you tell an ILD that causes ground glass is equal to NSIP, such an important point for exam. Even UIP can produce ground glassing at certain areas. Many other ILDs also can produce ground glassing, but it's a prototype, it's a stereotypical question exam. Ground glassing, ILD, IIP is equal to NSIP, non-specific interstitial pneumonia. Traditionally, remember, this ground glass appearance has been linked to steroid responsiveness. They told whenever there is a ground glass, they told it will be responsive to steroid, which means that's why they told NSIP must be steroid responsiveness. But it's not true in the sense. Many subsequent trials have proved all the ground glassing are not steroid responsive and all NSIPs are not steroid responsive, which means whenever you encounter a ground glass, you have to see whether there is any architectural distortion or not. Suppose if there is no architectural distortion, that kind of ground glasses will be steroid responsive. Definitely. No need to worry about that. So this is what you will see in a typical NSIP case. There will be no architectural distortion. It will be purely ground glass. So this is what you see in a typical non-specific interstitial pneumonia. But suppose if you have a ground glass, but you have architectural distortion, that's indirectly meaning it's a fibrosis. Architectural distortion. Anywhere there is fibrosis, there will be architectural distortion. Like cirrhosis, liver fibrosis, you get architectural distortion. Similarly, lung fibrosis, you get architectural distortion. So if there is an architectural distortion, that you will call it as not steroid responsive. They will not be responding to steroid. So not all ground glasses are steroid responsive. And this type of NSIP, typically they call it as a new name called a fibrosing NSIP. It will not be responding to steroids. So you have to know, not all ground glasses are steroid responsive as far as ILDs are concerned. Apart from that, it can happen in a pure airspace disease. Now we have seen an example of where in a pure interstitial disease, you got a ground glass. NSIP is an interstitial disease. But now you are seeing in a pure airspace disease where you are going to get a ground glass. Typically, this CT belongs to a patient who's having a Goodpasture syndrome. This is a diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage is a airspace disease. It is typically an airspace disease. There's no doubt about that because hemorrhage happens within the alveoli only. It's an alveolar filling process. But it may not fill completely. That's why sometimes it may result in partial displacement of the air causing ground glassing. But you can see these are areas of consolidation which you have seen already. These are definite alveolar filling here. It's a filling process that's happened here. That's why it looks like a consolidation. Entire air from that area is replaced and filled with blood. And you can see a lot of other areas. You can see these full areas everywhere here. everywhere in these areas, it looks like air is partially displaced. It's looking somewhere in between. That's why these are areas of ground glassing. And this is a patient with a diffuse alveolar hemorrhage. When we did the bronchial lavage to this patient, it looked like bloody ball, full of blood. So this is definitely a airspace disease example that produces ground glass. And third example is a combined airspace and interstitial involvement, but still you can get a ground glass. What is that? Typical example, this is a pulmonary edema. And in fact, this is a cardiogenic pulmonary edema. This is a patient who presented with sudden onset breathlessness in the night 2 a.m. 64-year-old lady who had a history of bypass surgery 6 years ago, around 58 years of age, and now came with a sudden onset breathlessness. This history is there. What do you suspect? It's a pulmonary edema. It's a cardiogenic cause. That's what with the history itself I'll tell it's a cardiogenic pulmonary edema. And the patient had bilateral basal growths. I don't know why the hell they took a CT, but they still took a CT. And this is what happened. This is what is seen in the CT. It's a typical ground glass. What is suspecting? It's a cardiogenic pulmonary edema. NT-proBNP in this patient was 34,000. So this is definitely a cardiogenic pulmonary edema. How we can tell is the fact that I can see history, examination, bilateral basal Krebs, and your NT-proBNP. All this telling definitely it's a cardiogenic pulmonary. I don't need a CT. But in CT, let us see what you're seeing. You can see this interstitial thickening. Definitely the septae are thickened. That is because of the pulmonary venous congestion. Clear? That is due to pulmonary venous congestion. And you can see one thickened line here. That is nothing but the oblique fissure on the left side. That's a left oblique fissure. That's thickened. That is because of the fluid, edema. And you can see a lot of areas of ground glassing. You can see this area is a ground glassed area. This area is ground glassed. This areas, yes, they are still ground glassed. And all this ground glassing is due to the partial displacement of the air with water. That is edema. So that's why this is a case of a pulmonary edema. And you can see these are having a gravitogenic distribution. As you move posteriorly, this is the posterior area. As you move posteriorly, you see more and more densities. That is because water is going to go its natural course towards the gravity. Similarly, here you can see this is also more towards the posterior region. Why? Because again, water is gravity. It goes towards the gravity. Here it is blood. Blood is moving towards the gravity, which is a fluid. That's why. So we have seen 3 examples where one is a pure interstitial disease causing ground glass, pure airspace disease causing ground glass, or a pure combined interstitial and airspace disease causing ground glass appearance as well. Which means ground glassing is something which can be caused by anything. That's what I'm trying to tell. So what are the conditions that produce ground glass? So typically any condition that fills the airways or any condition that affects the interstitium can produce a ground glass. It's a combination of a consolidation and the interstitial disease, both of which can produce ground glass. So if you still want to know about the ground glasses, let us see. Some acute ground glass appearance are there where water can fill. It's a filling process where water can partially fill the alveoli and partially eliminate the air, causing a ground glass like pulmonary edema and ARDS. Fine. You can get in where the blood can partially fill. You know that it's diffuse alveolar hemorrhage or a pulmonary hemorrhage. Or a pus can partially fill. All the cause of consolidation I'm telling you again. That's all. Where you can get with a pneumonia, bacterial, viral, mycoplasma, any pneumonia can produce this ground glass appearance. Or inflammatory cells can fill that. Like for example, acute eosinophilic pneumonia. Or it could be even an acute hypersensitivity pneumonitis. But as far as you know, hypersensitivity pneumonitis commonly produce a mosaic pattern, which I'll show you in some time. But this can also be there. Where you'll see chronic ground glass appearance. Chronic means usually it goes towards an interstitial process. That's ILD like. So some ILDs, typically if it's a chronic ground glass means I'll think about NSIP as the first possibility. This is the ILD that always in exam it's important, NSIP. It can be seen in UIP also, but always ground glass means it's NSIP, at least for exams. Then you can get with other filling conditions also, like bronchoalveolar carcinoma, very, very important. They can also produce ground glass. Consolidation, filling cause, bronchoalveolar carcinoma. Then you can get with organizing pneumonia like cryptogenic organizing pneumonia. You can get with chronic hypersensitivity pneumonitis, chronic hypersensitivity pneumonitis. I can also get with pulmonary alveolar proteinosis, rare, all these things. Clear? So, but in general, the most important of all the causes in this will be NSIP only. Remaining everything you know. This all you studied in consolidation itself. This all you studied again in consolidation itself. Only this is very important. That's a typical for ground glass. Remaining all these things will be having overlapping features. Clear? So this all about the ground glass. So once you know about this ground glassing, let us go to the next pattern, which might look like a ground glass to you, but there are some differences with the ground glass. This is called a mosaic pattern. Mosaic pattern. So where you are going to see the mosaic pattern, basically. Mosaic pattern, typically you can remember the mnemonic ABPH, like ABP, allergic bronchopulmonary aspergillosis. I'm going to remember as ABPH. A stands for asthma. And B stands for bronchiolitis obliterans. Typically after lung transplant, you can encounter this bronchiolitis obliterans. P stands for pulmonary embolus. And H stands for hypersensitivity pneumonitis. Hypersensitivity pneumonitis. But where this ground glassing, this mosaic pattern is most important is the hypersensitivity pneumonitis. In our radiology department, in my practice, whenever they give mosaic attenuation, I always think about hypersensitivity pneumonitis as the first possibility, especially if the patient is coming with a history of some typical organic exposure. Clear? So what is mosaic? You can see a lot of areas which has different densities. Though these all areas I'm marking have some density, and these all areas have some different density. You might not call ground glass. Ground glass has a different kind of an appearance. The lobulation and the like characterization of ground glass is different. This is like a ground glass only, but this we call typically as a mosaic pattern more than a ground glass. This is an overlap with ground glass, but still this is a typical mosaic appearance you will get. But in exam, if they ask you what is a mosaic pattern and what are the conditions, the first thing you have to think about is hypersensitivity pneumonitis. And this is another overlapping thing, maybe with a ground glass, that's called a crazy pavement appearance. Crazy pavement pattern. Where, what do you mean by crazy pavement? You can see areas of different attenuation. You can see the crazy pavement has different stones of different color, which means areas of different attenuation. And you can see the distinction between the stones very clearly. That's the idea here. Previously in ground glass and all, you didn't see the distinction between the septum very clearly. But here what you can do is, you can mark it up and see that you can see the distinction very clearly. A lot of areas are clearly distincted, which means the interstitial thickening is there. Interstitium is very clearly thickened. At the same time, you are seeing these all areas of ground glass. You can see these are all areas of ground glass appearance interspersed with normally looking lung. So this is what we called as a crazy pavement appearance characteristically. We can see some few more examples of this crazy pavement appearance. Like this is another example of a crazy pavement appearance. What you can see is very simple. Again, you can see the interstitium is very prominent. All the areas, you can see the interstitium is extremely prominent in many areas. You can see this typical interstitium is prominent here, and you are seeing a lot of areas that are having this ground glassing. These are all ground glass appearance. So, and in between you are having normal areas also, like this, a different attenuation. This is characteristic crazy pavement. Crazy pavement has the typical interstitial prominence along with interspersed ground glass with normal areas. So this is what we call the crazy pavement. And whenever they ask you about crazy pavement, the first thing in exam is PAP, always. Pulmonary alveolar proteinosis. This is the first case to be described under this heading, crazy pavement appearance. But it's a very simple fact. Any disease that produces interstitial thickening as well as the airspace, air displacement from the airspace partially will result in crazy pavement. So what are the things that can cause? You can get in sarcoid. We can get in NSIP also, because here also it's an interstitial disease where you can get interstitial thickening along with partial displacement of air causing ground glass. And number 4, you can get in infection also, like pneumonia. You can get in a lot of neoplasm, and this is a very important one. Neoplasm like bronchoalveolar carcinoma. Then you can get in pulmonary edemas, either a cardiogenic or non-cardiogenic, or you can even get in an organizing pneumonia, like a COP. So many conditions you can get this. Again, same, everything is one and the other, but the mechanism you can see that the overlap is the reason for, overlap happens because of the mechanism. The reason is the mechanism it causes. All these are very similar mechanisms. But if it's, the patterns are different, that's all. The mechanisms are different, patterns are different because of that, but the disease that produces them are the same. They're not going to be much different because the same can result in different amounts of air displacement, different attenuation in the CT. That's all. So this is crazy pavement. Characteristic example, in exam they give crazy pavement, it is always PAP. That's all. Don't diagnose anything else. If you don't have PAP, then think of something else. Pulmonary alveolar proteinosis. Clear? So what is the next pattern we are going to see? Next pattern what you are going to see is nodular pattern. This is a nodular pattern we are going to see. As I told you, again I can take a secondary pulmonary lobule and show you where you will get a nodular pattern. So this is a secondary pulmonary lobule. I am drawing this once again. Suppose I have two secondary pulmonary nodules. You have a bronchus here. You have a lobular bronchus or lobular bronchiole. Suppose if you have a nodular distribution along this septum. So because your lymph vessels are going to pass along the interlobular septum, so this type of nodular distribution is what we are going to call it as perilymphatic distribution. Suppose if your nodular distribution is present in the center, so the center of the secondary pulmonary lobule, this is what we are going to call it as a centrilobular distribution of nodules. It's a centrilobular nodular distribution. Supposedly, if you have distribution throughout, not any specific location, this is what we refer to as a random distribution of nodules. Remember, like whenever you have this random or perilymphatic nodules, these are the two things. This perilymphatic nodules and the random nodules will have pleural nodules also, usually. They'll have pleural nodules also. But the centrilobular, because they are located in the center and lot away from the pleura, the centrilobular nodular distribution will not have any pleural nodules. So this is how you distinguish in the CT. But if you see the CT, it's more easy. You can see this is definitely a random distribution where you can see the pleural based nodules also there. And typically you can see the perilymphatic distribution also along the lymphatics, and again you can see pleural based nodules. But the centrilobular nodules, you are not seeing the pleural based nodules. So these are centrilobular nodules. So these are the three different types of nodules that are seen and basically available. So in that I'll come to some special appearance that's called a tree in bud appearance. I'll come back to that in some time. So what is this is? This is a characteristic example of a perilymphatic nodular distribution. This is a perilymphatic nodular distribution. You can see very characteristically the nodules are located in the perilymphatic zone. This is the septum, and around that you are getting the nodules. So these are typical perilymphatic nodules. Whenever they tell perilymphatic nodules, the first differential diagnosis is always sarcoidosis. First differential diagnosis always sarcoidosis. Second one is the one of the deadliest differential diagnoses I told you, that is lymphangitis carcinomatosis. Lymphangitis carcinomatosis. This is the second DD that you have to think. But remember, lymphangitis carcinomatosis will be unilateral. Sarcoidosis will be bilateral. Lymphangitis carcinomatosis will be unilateral. Very rare possibility is silicosis. Silicosis is very, very rare. You don't generally get this kind of pattern. But sarcoidosis versus lymphangitis carcinomatosis, how are we going to find out? This patient is having a typical, you can see this is the septum and you are seeing a perilymphatic nodules. And this is definitely a sarcoidosis. Why I can tell? Because it's bilateral. Number one, perilymphatic distribution. Number two, at the same time, I am seeing mediastinal lymphadenopathy. Definitely it must be sarcoidosis. Lymph nodes, perilymphatic distribution of nodules, bilateral distribution, it is sarcoidosis. That's it. I told you already, it will be strictly unilateral most of the times, lymphangitis carcinomatosis. And you can also see the fact that the interstitial disease is also present, where you can see thickening of this left oblique fissure. That is typical of a ILD, interstitial lung disease. So a perilymphatic nodule, interstitial disease, lymphadenopathy, bilateral disease. What more you want to tell? It's not sarcoidosis. It is sarcoidosis for me. That's all. Then you can see this is an example of a random nodular distribution. You can see they don't have any specific pattern. You cannot find out anything. It's not perilymphatic, not centrilobular. You can see on the pleural base also many nodules. This is a pleural base nodule. So this is definitely a random distribution of nodules. What are the examples that produce random distribution? Typically due to miliary infection, some miliary infection. In our country, always this means it's a TB, it's a miliary TB. Always this pattern in India means it's TB only. First diagnosis of mine will be TB. Rarely it can happen with sarcoidosis. Sarcoidosis also can produce miliary distribution. Fungal infections rarely can produce miliary distribution, and metastasis rarely can produce miliary distribution. But in India, always it is TB. That's all. I will take it as TB. As simple as that. Then this is the centrilobular nodule distribution. You can see this is centrilobular nodules. You can see the pleural surface is very clear. You don't get any nodules near the pleural surface. So no pleural nodules, but your perilymphatic and your random distribution will have pleural based nodules also, but here there is no pleural based nodules, it's purely centrilobular. You can see only in the center of the secondary pulmonary lobule. This is secondary pulmonary lobule, and you can see only in the center of the secondary pulmonary lobule you can get this nodules. So what are the examples? Examples, you get in some infections, non-specific bronchial carcinoma, again non-specific, respiratory bronchiolitis possible, and hypersensitivity pneumonitis. Fourth example, hypersensitivity pneumonitis. These are some of the examples, but remember hypersensitivity pneumonitis in exam always means mosaic appearance. I've showed you already. So this could be there, but mosaic appearance is most important, especially for acute hypersensitivity pneumonitis. Clear? And there is a special pattern which many of you will not understand. That's called a tree in bud appearance. This is called a tree in bud appearance. What do you mean by a tree in bud appearance? So let us assume I'm drawing a 2 secondary pulmonary lobule again. Secondary pulmonary lobule again. This is a pleural base surface. So this is a lobular bronchiole. What happens is sometimes in infection, there will be a lot of secretions and pus production in the local area or cache-eating necrosis that will be produced that might be plugging this bronchus. So this plugging of this bronchus with secretions will be there. Along with that, there will be multiple satellite nodules. These are centrilobular nodules. These are nothing but neighboring secondary pulmonary lobule, where you can get centrilobular nodules like this. So when you have this kind of bronchus that is plugged with mucus, at the same time you are having this centrilobular nodules in the surrounding pulmonary nodule. This is a focus of infection actually, and this is what we refer to as tree in bud appearance, because it looks like a tree and a bud. This is called a tree in bud appearance. Very characteristic India is TB. The moment like radiologist sees tree in bud appearance, he will think of a TB only in India first thing. You can see very clearly here. You can see this is the bronchus that is supplying a particular secondary pulmonary lobule that is plugged with secretions. And you can see surrounding centrilobular nodules in the surrounding secondary pulmonary lobules. So these are surrounding secondary pulmonary lobules which is showing centrilobular nodules along with the plugged bronchus, lobular bronchiole, or before that a 15th generation or 14th generation bronchiole which is plugged with secretions, and this is a characteristic tree in bud appearance. Whenever you have this, it indicates a very active infection. Something is going on. But let us see what are the conditions that can produce tree in bud appearance. First is always infection, and mycobacterial infections are extremely common. I'm going to think about TB first. Second possibility, rarely it could be MAC, or sometimes it could be a bacterial or fungal infection. But in India, tree in bud, TB, always TB. Clear? Then you can get with airspace and airway disease also, like cystic fibrosis and bronchiectasis. Remember, in both these conditions, it is mucus plugging of the airways. It's very common. So that's why in these conditions also, if it's associated with some infection, you can get tree in bud appearance again. In allergic bronchopulmonary aspergillosis, again mucus plugging is very common. We have seen that's called a finger in glove sign. I've showed in the image also in aspergillus lung disease, and that is called, and that can also result in a tree in bud appearance. Finally, in aspiration, again you can get a tree in bud appearance. But in India, it's TB, always TB. Clear? This is tree in bud. So these are some of the important nodular appearances I have shown. Let us see some of the other appearances also, like cystic appearances. So this is cystic diseases, cystic lung disease. Like you can see, this is an example of a lymphangioliomyomatosis, where you can see multiple cysts. This is what we actually refer to as Swiss cheese appearance. This is multiple cysts you can see here, and this has a very high risk of precipitating pneumothorax. Clear? So whenever you call cyst, it should be fully air. That's all in the lung. You don't have anything else, only air. It's an extreme opposite of consolidation, where it is full of some other material except air, but here it's only air. You cannot even see a septum. You cannot even see an interstitium in that area. You cannot even see a interstitium in that area. This is what we refer to as cystic spaces, air spaces. This is LAM. This is lymphangioliomyomatosis, and this is what we refer to as that characteristic Swiss cheese appearance. And this is a patient with a Langerhans histiocytosis. Again, we can see a lot of cystic appearance in different areas that are randomly distributed. These are the cysts, full of air, nothing else, only air. That's all. And you can also see an associated pneumothorax. I told you there are two important ILDs that very commonly cause pneumothorax. One is your lymphangioliomatosis, and second is pulmonary Langerhans histiocytosis. This is a pneumothorax that is associated with the particular disease. So what are the diseases that produces cystic appearance? Number one, I already told you, LAM. Number two, it's pulmonary Langerhans histiocytosis. You can get with nematociles. Nematociles can be produced by infection also. Characteristic infections you have to remember for exam is Staphylococcus aureus can produce nematociles, and second one you can get with PCP pneumonia also. Number four, there is something called lymphoid interstitial pneumonia. It's called LIP, can produce cystic appearance. Honeycombing also may result in a cystic appearance that you see. So, but these are important to understand. Honeycombing is not that important. And next, I'll show you some features of emphysema. Emphysema also may look like similar to what you see, but history, your understanding, because radiology is something you have to understand with the history also. I cannot just like see the CT image and just interpret it. You have to have a strong, powerful and clinical background, that is history and clinical examination. So this is an emphysema patient. There will be hyperinflation, air trapping, all these things you can see in the CT. Apart from that, this is a typical example of a centrilobular emphysema or centriacinar emphysema or proximal acinar emphysema, where you can see the central part of the secondary pulmonary lobule is having air trapping and dilated. So this is centrilobular or centriacinar emphysema. Here you can see this is a panacinar emphysema. You go back to the emphysema topic and see panacinar emphysema will affect uniformly all the secondary pulmonary lobule, entire secondary pulmonary lobule and all the secondary pulmonary lobule, where the entire lobule will be, invisible and will be full of air. Clear? But here, how will you differentiate a panacinar versus centrilobular? From my perspective, not from a radiologist's perspective, from a clinician's perspective, when I see the image, I can actually visualize the interlobular septa here. If I'm able to visualize an interlobular septa in an emphysema, that must be centrilobular only, which means the dilation of the airways is seen in the center of the lobule. That's why I'm able to see the surrounding septa. But here I'm not able to see the surrounding septa properly. So which means the surrounding septa is so dilated or disrupted, resulting in it's like a uniform air space collection like appearance. This is definitely a panacinar emphysema or a panlobular emphysema. Here I can see most of the emphysematous collections are in the pleural based only. That is why this is a distal acinar emphysema. You go back to emphysema topic and see, and I would have explained all these things very clearly. So these are some of the cystic appearances which I want to tell. Clear? So with this we have seen almost everything with regards to ILD. Now let us try to consolidate. So what are the things you have to consolidate? What are the ILDs that are going to produce reticular appearance? ILDs that produce reticular appearance. Number one, always IPF, that is UIP. Second one, you will get with a chronic hypersensitivity pneumonitis, can produce reticulation. Third one, you can get with a NSIP, but rare, typically you will get with fibrotic NSIP. I told you, this only will produce architectural distortion, fibrosis. Usual NSIP, typical NSIP will produce only ground glassing. Number four, PAP, rarely can produce. Next, what are the ILDs that produce consolidation? Typically, number one is COP, that is cryptogenic organizing pneumonia. Second, in lot of eosinophilic lung diseases like chronic eosinophilic pneumonia, acute eosinophilic pneumonia, where eosinophils will be plugging the alveoli, causing that consolidation kind of appearance and displacement of air. Eosinophilic lung diseases, best example is chronic eosinophilic pneumonia. Third one is the ground glass. So what are the diseases that tend to produce ground glass? Number one, NSIP, NSIP, NSIP. Your typical NSIP is going to produce ground glass appearance only. Apart from that, respiratory bronchiolitis, ILD can produce ground glassing. Desquamative industrial pneumonia, acute hypersensitivity pneumonitis. Because one of the variant of ground glass is mosaic appearance, and that's what you will get in acute hypersensitivity pneumonitis. Very common. I have told you this multiple times. Then lymphoindustrial pneumonia. All these things can produce this typical appearance called a ground glass. And then you have nodules and masses, nodular appearance, typically sarcoid. The moment I tell nodules, it's always sarcoidosis. Next is silicosis, but rare. And cold workers pneumoconiosis, again rare. You can get in lymphangitis, carcinomatosis, because all these things is going to produce perilymphatic distribution of nodules. Perilymphatic distribution of nodules. Whenever I have perilymphatic distribution, my DD will be sarcoidosis and lymphangitis, carcinomatosis. Bilateral with lymphadenopathy, sarcoidosis. Unilateral without lymphadenopathy, go for lymphangitis, carcinomatosis. As simple as that. That's all. Then you have cystic changes. Cystic changes, only two I need. One is lymphangioliomyomatosis and pulmonary Langerhans histiocytosis. Very rarely you can get with LIP, that is lymphointerstitial pneumonia. All these things we have discussed. Now, some time back only I told you LIP can produce cystic appearance, that is lymphoid interstitial pneumonia. Clear? So let us assume just one example. So now if you tell, sir, all these things you are telling now, I do remember all these things in fingertips, but I am telling, but you might be asking me the question, how can I remember and what is the most important for exam? Simple. Reticular IPF, that's all. Consolidation, COP and eosinophilic lung disorders. Ground glass means NSIP, that's all. Nodules means sarcoidosis and lymphangitis, especially perilymphatic nodules means sarcoidosis and lymphangitis, carcinomatosis. Cystic means LAM and pulmonary Langerhans histiocytosis. That's all. I want you to remember only this much, nothing else. If you remember this, you are the rock star in exam. That's all. Clear? Then we are moving on to the ball appearances. That is bronchoalveolar lavage appearances. Is ball important? Actually in ILD, it's not important. And it's going to be non-specific and usually non-diagnostic most of the time. But in certain case, it might be helpful. Like what? So they will ask you lymphocytic ball. Especially if you see lymphocytosis more than or equal to 40%, this can happen only in very few conditions. Number one, you can get in sarcoidosis. And number two, you can get in hypersensitivity pneumonitis. You can get in hypersensitivity pneumonitis. But how to differentiate between them? Sarcoidosis will have CD4, CD8 ratio of more than or equal to 2. Especially if it's more than 4, it's very, very specific for sarcoidosis. This is a very important point, man. Which means CD4 will be more than CD8 here. That's the idea. Here the CD4 will be more than CD8. But if you take hypersensitivity pneumonitis, your CD4, CD8 ratio will be less than 1. Which means it's clearly telling you CD4 is actually less than CD8 here. Because the ratio is less than 1. So this is a very important differentials, very important for exam, the ratio. Next, if you have a eosinophilia, that to very high range eosinophilia, more than 30%, you are going to diagnose only acute eosinophilic pneumonia and chronic eosinophilic pneumonia. Only these two, nothing else. That high eosinophils you won't see in any other conditions. Then mixed cellularity, they don't have any value, where all the cells will be increased, like NSIP, UIP, COP, connective tissue disorder related ILD, drug related ILD. All these things are basic classic conditions which has mixed cellularity pattern, which is of very, very limited value. You need not even look out this. This is not important at all. But one specific ball finding is there. One important and specific ball finding is there. That is when you see a milky ball. Very, very important ball finding. When you see a milky ball, and if you suspect to histology, you're going to see PAS positive proteinaceous material. When you see PAS positive material, these are called PAS positive flocculent material. I'll show you what is that. PAS positive flocculent density. This is PAP, pulmonary alveolar proteinosis. Let us see that image. So you can see this is the normal bronchial lavage. This is a very, very milky ball. And you can see these are the PAS positive flocculent material, proteinaceous material. This is nothing but the surfactant actually. That is expected and coming out in ball also, because it's either overproduced in PAP or undercleared in PAP. So this is a typical pulmonary alveolar proteinosis. So point number 1 finished. So second importance where ball is, you will see something called lipid-laden macrophages. Lipid-laden macrophages, it's a sign of chronic aspiration, chronic microaspiration, otherwise referred to as lipoid pneumonia. Lipoid pneumonia. I told you chronic aspiration also can lead to ILD. One of the important ILD with known causes in that list I would have given chronic aspiration. So there you will see this lipid-laden macrophages. And you can see with oil red, Sudan black, right stain, so many stains you can use this. Number 3, if more than or equal to 5% cells in ball are, when you take ball, you get cells also along with the wash. So if more than 5% of the cells are CD1A positive, obviously you know this is a pulmonary Langerhans histiocytosis, because it's a Langerhans cell, so definitely they must be CD1A positive. Obviously in electron microscopy you are going to look out for this classic tennis racket appearance of Bierbeck granules. Clear? We have seen in detail in hematology section. Then final investigation that you can do in a patient with the ILD is serology. Very important actually, not final. It's a very important investigation, because you have to rule out many other secondary conditions that causes ILD, because IAPs are the primary are there, but before diagnosing as idiopathic you have to rule out all the secondary conditions. Best examples will be ANA, then anti-SCL70 antibodies, your extractable nuclear antigen profile completely, which includes your anti-Jo1, anti-synthetase antibodies also, which means all the antibody profile you have to do completely to rule out connective tissue disorder related ILD. Very important. All the antibodies, it's better to finish it off. Then lung biopsy. Is it really indicated? Answer is not always. It's not indicated in all the patients. It's only indicated especially when your diagnosis is uncertain. If you have an uncertain diagnosis, then your lung biopsy may be indicated. Otherwise, it is really not indicated. For example, if you have a typical radiographic features of IPF, you need not do a lung biopsy at all. So if your typical feature of a sarcoidosis is there, like lymphadenopathy, perilymphatic nodular distribution, hilar nodes, mediastinal nodes, no need to do a lung biopsy. You can straight away start a treatment. But there are some important thing to know, that especially when will you diagnose IPF consistently, concretely when will you diagnose. So there is something called a definite UIP. When you call a definite UIP, this is very important for exams. Definite UIP. When you have all this, when you have a subpleural and basal distribution of lesions, and the lesion is reticular pattern, and you have honeycombing with traction bronchiectasis. Traction bronchiectasis. Plus at the same time, there should be absence of features that are inconsistent with IUIP, that are inconsistent with usual interstitial pneumonia, UIP pattern. So if you have this, definitely it is UIP only. So what are the features that are inconsistent with your usual interstitial pneumonia pattern? Number 1, if the involvement is upper to mid zone, upper or mid zone involvement is there. Number 2, peribronchovascular involvement is there. Remember, always, IPF means it must be basal only. You should never involve the upper or mid zone. That gives a strong, alternate possibility. Then if you have cystic involvement, you have multiple cystic appearance, or if you're having more of a ground glassing than reticular, which means you might be dealing with the NSIP. That's why. Number 5, if you have micronodules, could be sarcoidosis or TB, something else. If you have a diffuse mosaicism, mosaic appearance, or significant air trapping is seen, you are dealing with an emphysema then. Especially if it's more than 3 lobes, or if you are dealing with a consolidation pattern, definitely not UIP. You are dealing with some filling process. Very difficult to get a consolidation with UIP. Very, very rare. Even though possible, full fibrotic lesions, everything is coming and filling the alveoli, complete fibrosis filling the alveoli, then that is possible to get a consolidation there, but I don't think that is consistent with the diagnosis of UIP. So this is what we called as a definite UIP. If you have subpleural, basal, reticular densities, reticular thickening with honeycombing, plus or minus traction bronchiectasis, with absence of features that are inconsistent with UIP, which I told you all these lesions, especially the ground glassing and your upper lobe involvement, upper to mid zone involvement, more of cystic lesion, air trapping, this and all will definitely go against your UIP diagnosis. So which means your UIP is one thing that you can concretely diagnose with CT itself. You not do even a biopsy or don't have anything else to do. Suppose if you have only the first 2, the third one is not there, but this thing is there, then you can call it as a possible UIP. Still, you can start the treatment as UIP, but if you don't have this reticular, if you don't have that first 2 also means, then or you have anything that is inconsistent with UIP, then you have to do a lung biopsy. That's why. So if your diagnosis is uncertain, I told you, definitely you have to do a lung biopsy. So this is how you diagnose a UIP, that is IPF, idiopathic pulmonary fibrosis. Remember, subpleural, basal, reticular densities, reticular thickening with characteristic honeycombing and traction bronchiectasis with epicobasal gradient. That and all is not for you. Again, subpleural, basal, and reticular densities, reticular thickening with honeycombing and traction bronchiectasis. And why you get a traction bronchiectasis? Traction bronchiectasis because if you have a bronchus and this bronchus has a interstitial attachment in all the areas. Suppose these are going to get fibrosed, and this fibrosis will result in shortening of this interstitial fibers, which means they are going to get shortened. So this shortening will pull the bronchus and that becomes bigger, and that is because of the fibrosis of the interstitial zone. So this kind of pulling of the interstitial fibers due to fibrosis causing dilation of the bronchus is what we refer to as traction type bronchiectasis. This is called a traction bronchiectasis, and this is a very characteristic feature of ILD, especially when it's going for fibrosis. And whenever you have a traction bronchiectasis, it's not a good sign. It indicates fibrosis, in fact extensive fibrosis, and it's not going to respond to your steroid treatment if it's an idiopathic ILD. That's what it's going to tell. So that brings to the ultimate conclusion of this overview of ILDs. This is one of the very, very important videos I have made in the ILD segment, because even if you don't see the other videos, please be very sure about this particular video, because this is going to give you a lot of essential information that is needed for your entire practice, as well as it gives you a lot of boost in, like, it's like when you're going in a 100-meter race, and this video in ILD is like, it's giving you a kickstart of 50 meters already. So you have to run only the remaining 50 meters in ILD. That's it. So with this, I'll finish off this video. From the next video on, we'll be seeing some of the special types of ILD.